mobility. So it's 11:30, I'm gonna try to get this done in 20 minutes. Just a real quick reason for mobility. These are why mobility and ambulation with our patients is important. Obviously, blood clots, bone loss, joint contractures, and just stiffness overall. We all know, well, maybe not all of you yet. As I get older, I realize moving is really beneficial. Lung dysfunction, muscle loss, we decrease muscle strength by 1 to 1.5% per day by not getting up. Delirium, confusion, chronic weakness, constipation, decreased GI motility, and urine stasis. Just so you know, when therapy is involved with the patient, we're going to have the whiteboard filled out in each room. So we're gonna say, what does that patient require for transfer in terms of assist? So we'll have usually assist times 1 or 2 on that. And if they use a walker or a cane, always a gait belt should be circled. I'm gonna skip that. This is just so you know in your handout, this is something you can assess if you don't know. I know you guys are using the egress test for your assessment of patients, but if you don't even know from that standpoint, these are the 2 tests you can use to see if even bed mobility, just that initial, can they even function and get to the edge of the bed. These are 2 exercises you can do, or not exercises, tests I should say. And that egress test, simply it's a sit to stand. So first we're gonna ask our patient, can you get from supine to the edge of the bed? We wanna kind of look at that, assess that. How long did that take? Did it take them both hands? I try not to help them because part of it is like, if you're gonna go home, you should be able to do this at home. I'm not gonna be there to lend you a hand. So I'm looking at their ability to do that. How much time does it take? How much help do they end up needing from us? Then if that looks good, they're sitting on the edge of the bed, how does that balance look? And then you're gonna ask them to sit to stand. How does that look? And then if they're able to sit to stand, you're gonna have them march in place. Usually once they stand, if this is your first time to assess this patient and you don't know what they do, when they stand there, I just sort of have them weight shift right to left too. That's just a little added thing I do. And then you have them march in place, and then you can have them take a step forward and back. If that looks good, I have them alternate legs. They should be good to ambulate a short distance to the bedside commode, the bathroom if they feel comfortable, depending on what their prior level of function was too, right? And what they were here for. So that's it. It actually goes very quickly, that quick assessment. Proper body mechanics and mobility too is important from the standpoint that from therapy perspective, we work off of productivity. We have to see 8 to 10 patients per day. I don't think a lot of people know that. So when we do a call light for help, we really typically need help, either if it's to take over a patient. Happens to me when I put a patient in the bathroom and they said that it's gonna take me a while. It's like, okay, I don't have a while to stand and wait. So that's typically when we'll do a call light saying, hey, do you have somebody that can come over and just keep an eye on this patient for us so we can move on? So just understand we're working from a productivity standpoint, those 8 to 10 patients, and it's hard to get through those sometimes when we get stuck in a room. Mobility from a body mechanics standpoint, can I borrow you? Sure. Okay. Always thinking about keeping a neutral spine and bend from your knees and hips. So when you're always looking, you're looking at lifting just like you would do a normal squat as much as possible. Position that patient close to you as possible too to prevent strain. Set yourself up with a stable base of support. So it's usually they're kind of 1 foot in front of the other, a little bit wide base or side to side wide base depending on where you're going, what direction. Do not let the patient grab onto your neck or your butt. Use the gait belt when assisting patients, and also that really does help control the patient. So everybody's familiar with the gait belt, right? And just know when you put that gait belt on initially, when they're sitting, it may feel tight, but once they stand up, it will loosen a little bit. So I always make it snug when they're sitting. And then I also try to give the patient control. It's like, okay, you're gonna count to 3. They don't have a lot of control in the hospital, so this is one place where I can give them control. Go ahead and scoot forward to the edge of your chair. And I'm gonna kind of block their knees a little bit here. And I use my knees as that leverage point. So when I lift at the hips, I've got this to block so they're not flailing out. It helps control that lift up. All right, so I may have them put their hands on my elbow, and Laura, I'm gonna have you kind of lean forward and look over your knees, and you're gonna count to 3, and once we lift, we're gonna pivot over to here. And if you wanna take a step, that's when I open my legs up, okay? So I'm gonna keep my back straight, I'm not doing this. I'm gonna keep my back straight and get down here with them. Okay, Laura, when you're ready, count to 3.
1, 2, 3.
And then I have them push themselves back and adjust. I know that's much simpler than what real life is, but that gives you the visual. That gives you the visual of at least to save yourself. If I'm doing a 2-person, I'm going to have one person here. Usually I'll have the therapist will want to be on this side so they can guide that patient over for, not that you're not going to be successful, but it's my watch. I want to make sure the bum hits the chair. So I'm going to have them scoot forward to the front of the chair again. And again, I'm going to use my knee to block and create that pivot point. And I'm going to have them just put their hand here on my elbow. And I'm just going to have Karen assist too and watch her back. And her back's going to be straight. And, and Laura, you count to 3 and lean over and look at those toes.
1, 2, 3.
And we're going to lift over and then pivot.
This is nice.
Does anybody want to try it, or does anybody have any questions?
Placement of the gate belt, whether it's low or high, is that just A, the preference of the person using the gate belt, and B, like, depending on what surgery they have?
Yes and yes. Also, depending on the body shape, if you have kind of a pear-shaped patient that's really heavy through here, but they really thin up at top, I know when I lift that gate belt there, it's just going to slide up.
Right.
Also, the height of me in relation to the patient, if it's going to be, if it's going to be a taller patient versus a short patient as well. So, kind of 4 to 5 different factors for that. Good question.
If it's a taller patient, then do you go higher?
A taller patient, I will go low, and hopefully sometimes they have a little belly habitus here that I can anchor underneath if possible. The other thing I can do is kind of bring a, lift your right cheek and lift your left cheek. I guess we're going backwards.
It's like I did left and right.
That's what I always have to think about.
My right or your right?
So I can kind of use this too as a leverage for a tall person if I want to. I can bring that back and lift up as I'm lifting here to bring that, just to kind of give a little leverage up and do a pivot.
Yeah.
So that's something I can do.
I always feel completely useless on the real tall patients.
That's when you probably want to ask for a second person, just so you both have good leverage with the side, because a tall person, you definitely don't want it up here.
Right.
You want it at the waist so you can have that leverage come up. And if it's somebody really that tall and uncomfortable and questionable, I would ask for help.
Yeah, this one man I can recall, he was 6'4" something, and it was abdominal surgery. So I couldn't, it's like, what do I hang on to?
Yes, yeah. But using that belt under their hips to kind of help bring leverage up with them
Okay.
is a way to do that. And you can with a tall person, if you have somebody else with you on the other side, that's when you can use the belt under their hips and a belt higher, because if they're pretty good functionally, which you're gonna find, you'll know, you're gonna be able to kind of use that lower one initially to lift up and then take this one up, and
Okay,
they should be able to take over from there.
all right, thank you.
So, yeah, great questions. Any other questions?
Hey, one thing, I don't know if you already plan on talking about it, but it's something I've seen a couple times on patients, short arc quad. Could you talk about that?
Sure, short arc quad. I'm good if you're, okay. When they're in bed, this is what we teach for the total knees, well, total hips as well. When they come out of surgery, as for I'll use the same day discharges, so those patients aren't coming over here. But one of our primary guide to when they're gonna be ready for therapy is when they can perform a short arc quad. And that is when they're sitting in bed, they're here and of course they have, usually if it's a knee, they have a pillow under their ankle. So I take the pillow out and so they're straight down here. I will put that rolled pillow or towel or even my fist under their knee, so it just makes them lift up a little bit, and I ask them to lift their heel off the bed. That's a short arc quad. And then slowly lower it down. Sometimes if they don't get that concept, sometimes I'll just lift their heel up for them and say, okay, hold it there. Hold it, slowly lower it down. Does that make sense? This is a long arc quad. Okay, so the short arc is just this.
Just doing the knee to the toes.
Just lifting that heel off the bed with a little lift under the knee, the heel off the bed. That tells us the quads are activated, so it tells us that they should be able to stand and control a little bit more. Does that answer your question for that?
And what was it called?
A short arc quad,
Short R?
short arc, A-R-C,
Oh, okay.
and you'll see S-A-Q as the
Okay.
abbreviation.
I mean, I know I've talked about it with you before, but it's something that I saw today as well.
Okay.
Well, last night and today on one of my patients.
Okay.
Again, I've seen it once, and then I saw it this time on my patient where they didn't have that ability.
Oh,
or
yes.
So they weren't able to safely get up at that point.
Yes,
So,
our late case last night.
yes.
Okay, yeah, so that's the short arc quad. Usually if they're over here and therapy has seen them and we've gotten them up, again, that will be on the communication board for you. And they should be able to actively do a short arc quad. So we just went through the sit to stand, and you have these on your handout. The main thing is giving that patient enough cues for them to do the work, right? We shouldn't need to be doing all that lifting. So we want them to actively help us. So the main thing is giving them enough information to have them actively support and help us. Talked about the gait belt already. And this is just different variations. You can use that momentum. So when they're sitting here and you say, okay, you're gonna count to 3 and we're gonna rock, they're at the front of the chair and you got a hold of them and they're gonna say, okay, 1, 2, 3. And sometimes you may have to do a variation of that and just go 1, 2, up and hover, and then down. Okay, 1. So sometimes they need that activation to get their glutes activated to stand all the way up. So use that to your advantage if you need to. And again, once they stand, not going right into walking once they stand, having them really work on tucking that pelvis under them, rocking from side to side so that they get their bearings, they can get their blood pressure stable, and then walking. And these are just, I just want to make sure we included some of those. We did the pivot transfer. If they have knee buckling, that's why I like blocking at the knees with my knees, because that gives you that lever point. So their knees aren't going to fall out, their legs aren't going to collapse under you. You've got a hold of them, and you've got that pivot point to lift up from. And I just included all of that information in there. So the one thing, possible trying to transfer to the strong side of the patient, and also surgery from a surgery standpoint, also when you're walking a patient and ambulating with them, then staying on that strong side. Having a second person behind following if you need to. Actually, when you're walking, you want to be on the weak side, but when you're transferring, be on the strong side. And then when ambulating with a patient, stay on the weaker side, because if they collapse, that's what the side that they're going to collapse to, right? So you want to be there to get a direct hold of that. Use the gait belt to direct that patient's center of mass back over their base of support. That's why that gait belt is so important. You know, sometimes we've guided them down to our thigh and just kind of come in a kneeling position. That happened just back here in patient 32, I think, a couple months ago. And then pull the patient towards you or another stable object and a slow descent to the floor. That's why those gait belts are really helpful. So, does anybody have any questions? Did we cover everything we wanted to cover? Does anybody want to practice?
Oh, sorry.
Look at that. If you have a question about a patient and how they transfer and you're not sure, part of what the therapy team does is if they have a patient that is a difficult transfer, our practice is to have either the PCA or the nurse come in and do that transfer with us so they see what that looks like, so that there can kind of be safe handoff from shift to shift, so they understand what that can look like and how we can support each other in mobility. When I talked about mobility, that mobility is important again, like I said before, for the reasons up on the slide, but also from therapy. A lot of times, like even simple from getting to the bed to the chair, if therapy comes in and that's all we do is get the patient from the bed to the chair each time, we don't progress the patient from a therapy standpoint. You know, if we're duplicating that each time, so it's great when the patients are up to the chair for us, so we can progress our therapy session to do other things so that they can go home and not to a SNF. But if you have a question about how a patient transfers or anything, just ask therapy and we'll come in and go through that with you and make you feel more comfortable. Okay, thank you.
Thank you.